This was known as a Johnson twin wire. It was a horizontal bracket here with a groove here and a little key that locked over the top. Two very light wires were used. It gained a lot of popularity in the beginning because of the rapidity of tooth movement. This wasn't the first light wire technique. The first one was actually the universal technique. This was developed by Spencer Atkinson when he was teaching with angle. What he envisioned was the maintenance of the ribbon technique. And if you can see here, he had this pin that was bent over the top, or could be tied in like so. This gained an awful lot of popularity in certain areas around the country, particularly back in Kansas where it was modified and taught. So it started out with a light leveling wire and had two systems, one for alignment and then one for torque. It just became bothersome to tie in two wires, and this was one of its downfalls. Now I also mentioned the labio-lingual technique. Here's a vertical half-round tube with a lingual arch, with a lock here to bend this in and hold it in place. This was the first appliance I constructed and designed and used. Now this is to receive long finger springs so that it could have a lot of soft action. The labio wire also had a stop here like you see, which was later adapted by Wilson, where he put a push coil spring in here and activated this labial appliance for intermaxillary elastics. So the primary action in class 2 would be back here against the molar. So you can see where the Wilson technique came from. He also put two tubes here with a friction lock so to make it simple, and that got away from this lock here. Now at the same time he was doing this, Crozat came along and trained by Mershon in labio-lingual, and he developed clasps and a basic lingual with a high labial so that he could use these finger springs to rotate individual teeth, and then he could hang this down here and use it for an elastic. And by advancing this, he also could put the primary force against the molar first. Now keep in mind our philosophy of unlocking the malocclusion. Both of these techniques work with movement of the molar first. Now please keep that in mind as we begin to get into bioprogressive, that we've utilized this order in technique of selection and determination of the primary teeth needed first. Now when you move the molar first, the premolars will drift. I've seen lower second premolars that have drifted distally into the space of an extracted lower first molar several millimeters without tipping. It's amazing. I don't know how it operates, but the premolars will drift bodily, but the molar won't. It'll tip. But given the chance, premolars will drift distally when you move the molar back first. If I extract the second premolar and hold the first molar, it's amazing how the first bicuspid will drift distally in both arches. We're so much accustomed to thinking about mesial drift all the time. Everything's always coming forward. So we have to condition ourselves to the fact that a canine and a first premolar, or both premolars, will drift distally if we give them the opportunity. Along about 1950, we started putting two brackets on incisors and molars when they needed brackets. This is about 8.5 to 9 millimeters wide. So we started putting two brackets on these teeth so that we could eliminate the staple. Now what that did was to cut down the space between the teeth. What I'm talking about is the working space. So using Siamese brackets, and Siamese is a trade name that Rocky Mountain developed. This was in 1950 when we started this. So naturally, when I went to California in 1952, I started soldering and made out a technique where I could solder 2 brackets on one band. It was very, very difficult to solder one, come back and solder the next one exactly so that a wire would go in here with no friction. So as soon as they started milling these in the same in the line and giving them to us on a pad, I was still in gold. So the only company that ever made these in gold was a company out of Philadelphia called Baker. And so between 1952 and 1955, I used Siamese gold soldered on to gold bands. Now what does that do if I have a big bracket here and 2 of them, one on either tooth? What that did was to cut down the working space between each tooth. In the lower incised area, it meant 3 millimeters of space. So in 1950, I started using 21 square gold wire with Siamese brackets. I needed a smaller wire to create a lesser force than I would with the big steel wires that we'd used with the single brackets. So the Siamese bracket was the cause of the 18 slot. These canines, the upper canines are all right, but don't get misled with these canines here, because we found now that the canine should be virtually upright. For the first 30 years of my profession, I made a mistake in the lower canine. I tipped the lower canine forward like we tipped the upper canine. Our prosthetics textbook will show the lower canine in a mesial inclination. Number 1, it doesn't have a lingual inclination, it has a labial inclination. But in the beginning, I thought that they were probably equal due to the discipline in prosthetics, and nobody questioned it. Then I began to notice that I was starting to finish patients. The root of the canine was back against the lower first premolar root. Then in 1988, in order to write chapter 16 in the book, you notice a lot of these skulls have bands on them and wires bent at right angles. Well, I took all these, put these bands on and the brackets on and the wires on, and then I took x-rays of them. So now I do this study. And to my amazement, it's the canine that was the mistake. Instead of being 7 degrees, it should be 2 degrees. Or virtually straight upright, mesiodistally. See? So these are mistakes, and I'm pointing them out to you now so that you won't get this in your brain in the wrong way. Even these are misleading because the lower laterals should slant slightly to the distal. But what I'm talking about here are the movements that took place in 1952. I was taught in Tweed technique. I helped teach it in University of Illinois. And I was one of these vigorous guys that wanted to go in there and get it done. I had single torquing keys and double torquing keys. And I remember holding a child's head so that he wouldn't get away from me. It was painful. Not only is it painful to do, but they had a lot of pain when they went home. Now that wasn't uncommon for people with the Edgewise System in those years. We had no conception of how much force was needed and no conception of how much was really being placed. 2 investigators around the world were working at the same time. Reitan in Norway published his work, and he called it The Initial Tissue Reaction, published in 1950. Story came along and measured forces. In 1952. I was on a program with Reitan in 1958 in Copenhagen. And so when I went to Australia, my first visit in 1964, I made it a point to go and visit Story at the university. So I spent a lot of time discussing his work, the experimental setup, the protocol, his conclusions now, 12 years after he'd done the work in the beginning. Story was not an orthodontist. Smith was not an orthodontist. Story was a bone biologist. When I visited him, he was the dean of the school. What he was doing was studying bone reaction. So he had no real vested interest in any technique at all. Now, what he showed here was this. He could measure the movement of the canine along this line, and he could measure the movement of the posterior segment along this line. Now, this was designed for translatory movement. Now he found that he could measure then how much force he would put on with this loop. He could activate it a little bit or a lot to retract the canine. Now, when he got forces over 300 grams, most of the movement took place with anterior movement of these posterior teeth. When he was down in around 175 grams, this tooth would move. And due to the friction set up in this assembly, when he got down to less than 150 grams, the movement was slowed down. But this is one of the theories of differential force that was selected by Begg. So we got a lot of gauges in the 1950s and started measuring the amount of force that we were using. And we were too heavy. Furthermore, I tried to develop systems which would be frictionless. So another principle is involved. If I'm going to slide a tooth down a wire, I'll go slow here so that you understand this, and you'll get the idea of the reasons that I do the things I do. If I have to slide a tooth down the wire, I have to first of all use enough force to overcome the friction. Now maybe in some patients friction may not be too bad when you've got the teeth parallel. Child doesn't eat very heavy foods, and you've got things nice and straight to begin with. But if they eat very much during the course of the treatment, the wire is going to take a little curve. Every time they eat, they're going to be working on the wire. And friction can sometimes be very formidable. So I have to use more force to slide than is necessary to move the tooth. That's one factor. What is the other? The control of the root. Because if I want to move the tooth, I want to keep the root in between the buccal and lingual plate. Now, I hope you understood all of the factors that I just brought up, because we started out years ago putting push coils and pushing teeth down the wire. So sliding mechanics has been here for at least 50 years. Now, why did I give that up and go to sections then? So that I could individually control the root. And in the beginning I went to push coil sections. Then I said I'd have to have a loop system that's frictionless. So now you understand my loop designs. Because the more force I need, the more I endanger my posterior anchorage. So you understand the importance of Story's work. And the idea is to protect your anchorage and move the tooth you want to move. Now if you deliberately want to move your back teeth forward, go ahead. But if that's the case, why did you extract in the first place? There was a paper, The Use of Reverse Headgear in Extraction Cases. Now think about it. The use of reverse headgear in extraction cases. Now here was the crux of what he was trying to say. He had some arch length problems and extracted. Now he started to get along in the treatment, found that the face was too flat. So he put a reverse headgear on to keep the face from becoming so flat. So he wanted to advance the incisors and the lower arch for the sake of the face after it extracted when he shouldn't have. I was there in the audience when he read the paper, and it was supervised by a couple of the members. Everybody thought it was a wonderful paper. I almost vomited. Because what it implied was that you'd misdiagnosed and misprognosed and mistreatment plan. If you're doing that, then why did you extract? So this is what we were into in the 1950s. So you can see now where a lot of my early initiation in Bioprogressive came from. Now the second thing that happened was the explanation for why it happened. Because if you put too much force per unit area on, you're not dealing with force, you're dealing with pressure. Pressure is the distribution of the force. If I'm using a section and I activate the loop, you have the same force on either end. But if I've got 4 teeth, if I've got 1, 2, 3, 4, 5 roots, if I got the second molar banded, I've got 2 roots and a second premolar. I've got 6 roots that I'm activating against 1 root. So I've got a lot more surface area on one side than I do on the other. What we have then is a difference in the pressure. Now, if I put on then a force of 175 grams and up on the canine, that's distributed on a smaller area per unit, force per unit area on the anchor teeth, but the surface area, the on-face surface area for the movement of a canine is about 75 grams. I've got a broad root on each one of my molars, and I've got about 60 on the bicuspid. So let's just say I've got 250 against 75. Now I put the same force on when I activate the loop. Now how is that force per unit area distributed? 75 versus 250. Now, if I put that on too heavy, I squeeze out the interstitial fluid. My cells can't get oxygen. Blood supply is limited. I don't get the nutrients. That then produces a local area of hyalinization like condensation of connective tissue. What really happens is not hyaline. It's not hyalinization. What happens is the collagen fibers have all been pushed together so that there's no space between them. Story called it a cell-free area. Ricketts called it a sclerotic change. We were all talking about the same thing. I picked the name sclerotic up from my experience with x-rays and bones. We see with an increased stress on bone a sclerosis, a condensation, and that's what's taking place there. Now, if you just turn that around, if you want to increase your anchorage, then you want to produce that. If you can do so without inviting necrosis. So now you're looking at the concept of cortical anchorage or cortical avoidance. Then we come along with a bag technique. He turned the ribbon bracket upside down. Instead of entering from the incisal, he entered from the gingival side. And he wanted light, continuous forces, and so he went to round wire. To torque the tooth, he put an auxiliary loop in, or in this instance, he put a little stop bend in here so he could bring the incisors together. He had a little stop here to keep this from going back through the canine. So he's moving these tooth together and moving these out all in one shot. Now, the real problem with the ribbon bracket was that there's no purchase in the wire, there's no slot here that will produce an angulation of the tooth. So to control angulation, he had to use an auxiliary spring, which lacked finite control. Now we come up then to the Edgewise system. Edgewise was that you can control torque and angulation and step bends. Now here in the upper, as I've said a couple of times, this is depressed where it shouldn't be, and the upper is not rotated, the upper molar is not rotated enough. There has to be a gable and a bayonet, and there should be a step right here to step the bicuspid out. So this was the old Edgewise. In the lower, this was too far in. There was no step here.
ここはステップが必要なところなのに入っていない。
And the lower wasn't rotated enough.
から間隔6番も十分に回転が効いていません。
This distal cusp almost should be in almost the middle of the second bicuspid, second molar. In 1950, I went through the regular course. The orthodontic course. It wasn't the golf course. It was a course, and I became an assistant under Downs in the clinic. So I was starting to teach technique. This lasted 6 months. Dr. Brody came to me one day. He said, Rick, we'd just as soon you wouldn't teach technique. What I want you to do, however, is to give a course on the temporomandibular joint and occlusion. And he said, I want you to give it to the pedodontic graduates, to the periodontic graduates, to the orthodontic graduates, to the oral surgery department, to the department of oral diagnosis, and to the prosthodontic department. So, well, what do you want me to teach? Well, how basic do you want to be? He says, start from the beginning. I mean, you mean phylogenetics and comparative anatomy and all that? That's what I mean. So that's how I happen to have all these skulls here. I started going back and reviewing then all the different kinds of occlusion, even from the alligator, from the fish, from there on. And I guess it was 1955. I made application to get in the Angle Society. And what I had to show on the table in plaster was 10 finished cases. When I went to California also, I had come with growth forecasts. I was using expansion modalities that I'd learned about in cleft palate, and I never extracted more than 35% of my practice. All the people in the Angle Society were extracting 70%. So theoretically, in 1 out of 3, there would be a disagreement in how to treat them. And so I put out these 10 cases. In front of each case, there was a chair, a table about this, like this. About the length of 3 of these tables, a chair at each case. 10 of them. So there'd be a person sitting at each chair. Pretty soon somebody would say, hup, move to the next chair. It's like a game. Never in my life have I seen anybody get their cases examined as closely as mine were. Has anybody ever scrutinized results the way that mine were? Now why? Because I treated without extraction in a lot of cases. And I was using modalities that they hadn't seen before. At that time, nobody was using extraoral traction the way I was. And I had departed fundamentally from the basic ideal arch concept. I'd put 3 or 4 alterations in it. And that was like exception to their religion. There was one man at the meeting. And his name was Nance.
Nance.
The extraction cases that Dr. Nance showed were the finest I'd ever seen. The finish, the detail was extraordinary. So when he started going through my cases, I saw him out of the corner of the eye looking at these cases. And he'd go, you know. Then he'd see the next one. So he got halfway through looking at the cases, and he turned around and he says, "Where's Ricketts?" "I'm right behind you, Nance." Or Hayes, his name, first name is Hayes. "Right behind you, Hayes." He says, "Young man, where did you learn to handle your molars like this?" I said, "I didn't learn it from anybody. I taught myself." He says, "That's one of the finest job of management of molars I've ever seen." Now the result of this with the Edgewise technique was a plethora of extraction due to at least three things. One was the technique, what it caused. The second was the lack of respect for future growth. And the third was the appreciation of the variation in different patients. In 1962, I was asked to contribute a chapter to the Vistas in Orthodontics. My title was to be Clinical Research in Orthodontics. So I worked for about 6 months writing a paper in which I entitled Clinical Research in Orthodontics. I sent it in to Rydell and Krauss, who wrote the book, and they said that's not what we wanted. I said, my Lord, 6 months of work, 88 references. I said, now you tell me. No, we wanted just what you have done personally. So I rewrote all of the work that I had done, and so in 1962, this is a good level of my state of the art in 1962. And this is just about now the beginning of Bioprogressive. In theories, we had these debates as to how we were going to superimpose, but I knew by now that I could do something orthopedically. We had classified problems in the joint. We were making predictions or designings. We knew we could move molars distally, and we knew we could attribute some of the change to growth. We'd focused on aesthetics with the E-plane. At that time, I called it distant anchorage rather than transformal anchorage. We were measuring forces and calculating pressures. We had described cortical and muscle anchorage. We'd done a lot of work in myofunctional therapy. As I said, we'd classified the lips, the tongue, and the TMJ, gone completely into lighter forces. Made a science of biomechanics. And we're using the computer for diagnosis and for management. By now we had pre-mounted brackets and tubes and gone into preformed bands in a wholesale way. We prefabricated modules and arch wires. We went through a few years of using the screw and then came back to the quad helix. We now pretty well understood the virtues of cervical traction, sectioning of arches, measures to prevent the mandible from rotating open, anchorage reinforcement when we needed it. We modified the crozat. Surgery was primary in this era in the mandible. Lafort's hadn't been popular yet. Intrusion mechanics would be used. And we were beginning to focus down into 18 thousandths brackets and 16 thousandths blue alginate wire. This permitted us a lot of intraoral work.